For patients presenting with Class 3 morbid obesity, conservative lifestyle modifications carry a near-certain prognosis of failure. The metabolic state at this level is often too compromised for simple caloric restriction to overcome. Because weight loss via self-regulation is so statistically rare in extreme cases, bariatric surgery is commonly prescribed as the only definitive medical intervention. However, clinical data from Apollo Ayurveda hospitals demonstrates that a non-surgical resolution is possible through a targeted Ayurvedic protocol. This 45-year-old female patient was admitted at 145 kilograms with a BMI of 68.07, possessing zero independent mobility. Over several months of specialized treatment, her weight dropped 19 kilograms to 126, and her BMI fell to 59.15. These clinical results were achieved without surgical assistance or extreme caloric starvation. Ayurveda classifies this condition as Sthaulya, a syndrome of complex mechanical metabolic obstruction. Understanding the mechanics of this pathological fat accumulation allows clinicians to move beyond the scale and address the biological feedback loop directly. Clinical obesity originates as Meda Roga, a specific pathology of the adipose tissue channels. These are the Meda Vaha Srotas, the biological channels responsible for fat metabolism. Their physiological roots are anchored in the kidneys and the omentum, or the lining of the stomach. Pathogenesis begins when ama, dense, undigested metabolic waste, physically occludes these pathways. In a healthy body, vata, the biological force of wind and movement, travels through these channels to regulate digestive pace and metabolic transport. When vata wind strikes these ama blockages, it is trapped and forced to deflect sharply downward into digestive tract. This deflected wind acts like a bellows on Jatharagni, the central digestive fire, stoking it into a state of hyperactivity. This stoking produces a specific mechanical error, the false hunger feedback loop. The patient experiences intense, insatiable hunger as the overignited fire demands constant fuel. They are driven to consume more food simply to quiet the physical sensation of the fire. Because the main metabolic channels are blocked, this new nutrition cannot reach the muscles or bones. It routes exclusively into expanding fat cells, leaving the rest of the body's essential tissues in a state of starvation. Morbid obesity is a self-sustaining mechanical cycle. It cannot be resolved through willpower because the patient is biologically starving at a cellular level while expanding at the waist. The intervention strategy focuses on clearing the obstructed channels without depleting the patient's existing vital energy. Success depends on identifying the type of fat accumulation. Hypertrophic obesity involves the enlargement of existing cells, while hyperplastic obesity involves an increase in the total number of cells. This cellular distinction maps to the Ayurvedic concepts of lifestyle-induced accumulation versus bija swabhava, the patient's genetic predisposition. To dismantle stubborn, localized fat, clinicians employ Udvartana, a specialized dry powder massage. Udvartana utilizes medicated powders applied in a rigorous, retrograde motion, rubbing against the natural direction of body hair. The friction created by these granular powders mechanically mobilizes the subcutaneous fat and begins to liquefy the stagnant kapha. Systemic internal clearance is managed through Lekana Basti, or scraping enemas. By bypassing the upper digestive system, these treatments target visceral fat at the large intestine, the anatomical seat of vata wind. This protocol is supported by a precise diet utilizing moong dal soup and buttermilk to provide fuel that burns cleanly without adding to the ama obstruction. This combination of therapies successfully strips away the pathological obstruction while sustaining the dhatus, or essential tissues. The primary risk in morbid obesity treatment is systemic overdepletion. Practitioners often make the error of using only shodhana, aggressive purging, and langana, or severe fasting. This chart tracks the vata paradox. As the heavy kapha, the fat, is stripped away, the erratic vata wind energy spikes because it no longer has the insulation of the fat layer to ground it. When vata spikes into this danger zone, the patient develops markers of systemic distress, skin dryness, chronic itching, and the degradation of joint cartilage. This state is known as dhatu kshaya, the depletion of vital tissue. As the body's internal lubrication vanishes, the patient suffers from neurological symptoms and skeletal pain. Detoxification triggers a metabolic panic response in the nervous system. Detecting systemic starvation, the body initiates a rapid rebound, hoarding every possible calorie to replace the lost mass. Weight loss fails when clinicians destroy the fat without protecting the underlying vata stability. The Apollo Ayurveda case proves that navigating this vata paradox is the key to systemic resolution. Clinical success is defined by the restoration of metabolic markers and internal channel flow. This data shows the systemic shift. Total cholesterol dropped from 221 to 198, while triglycerides were reduced from 166 to 153. This improvement proves that the Meda Vaha Srotas are now clear. The internal transit of nutrients and fats has been restored to a healthy baseline. With the channels clear, the systemic metabolic fire has returned to normal. Because the vata wind is no longer trapped and deflecting, the patient's false hunger feedback loop is broken. Maintenance now shifts from shodhana, the purging of fat, to shamana therapies that pacify the body and preserve this new, unobstructed metabolic state. Classical Ayurveda resolves morbid obesity by physically dismantling the mechanical blockages of the body. True weight management is a matter of internal clearance, not starvation.